Since the initial bolus of studies, taking a look at single-agent immunotherapy that began to result around 2015 and then 2016, the field quickly moved on to taking a look at combinations. If the single drug had efficacy, perhaps giving it together with some other medications would have even greater efficacy. And the two areas in which this has been explored are IO-IO combinations, and then the ones that have been of interest that have led to some shift in FDA approvals have been chemotherapy plus immunotherapy, particularly in the treatment-naive first-line setting. Keynote-21G was a study that was also presented at the end of 2016 that led to accelerated approval of the regimen of carboplatin, pemetrexed, and pembrolizumab given in the first-line setting for lung adenocarcinoma patients. It's important to note that we have not yet had any trial data read out for squamous cell lung cancer patients. 21G was a randomized phase 2 trial, so smaller numbers, against standard of care carboplatin and pemetrexed, followed by maintenance pemetrexed in this population. And the intention to treat results were positive. The overall response rate was higher at 55% versus around 30%. PFS was also improved significantly, again, a hazard ratio of around 0.6. And overall survival, while not fully mature yet, and so we have to be cautious about this, an early peak last year demonstrated that the survival curves were beginning to separate as an important thing to note about this regimen. The trial on its surface then was encouraging, but the problem is in the details. And the details are important. We no longer think, as of the FDA approval of pembrolizumab in the first-line setting, of the first-line subgroup as a unified group of patients. We think of them at this point as the greater than equal to 50% or the less than 50% subgroup of patients, and we have our standard of care therapies based on that. Keynote-21G did not take that into consideration. It started before, of course, the FDA approval of pembrolizumab in the high PD-L1 expressors. And so if you take a look at the subgroups of patients by PD-L1 status, the PD-L1 0 patients, response rate seemed to be better than chemo. And the high expressors, PD-L1 greater than 50%, response rate was also better in the high expressors versus chemotherapy. There was, however, a problematic subgroup, the 1 to 49% of patients, which is about a third of the patients. It appeared that chemotherapy actually was better by response rate than pembrolizumab. That difference was something like 38% in favor of chemotherapy versus 26% in favor of pembrolizumab. And so because that's the case, and because the control arms are different depending on the degree of PD-L1 expression, while it is an FDA-approved regimen, I think we have to be careful about looking at the data and trying to figure out in whom to give. We have no direct guidance, for example, that in the greater than equal to 50% subgroup, that this triplet regimen is better than just pembrolizumab by itself. In fact, it may expose patients to more toxicity. You're giving more drugs and you're giving chemo in this subgroup of patients. We don't know yet prospectively what is better, so we have to be a little bit cautious about that. And we also have to be cautious because of that problematic 1 to 49% subgroup, that the other subgroups may not be as great as might be evident if the numbers were higher. And so there is a confirmatory randomized phase 3 trial where the top-line results have just been read out. This is Keynote-189. This was, again, in the intention to treat population, a positive study, but we will have to see on its presentation later this year what the different subgroups look like and whether or not there is equal efficacy among these subgroups before, for me, we roll these out in terms of treating our patients. The clinical implications of Keynote-21G we began to see shortly after its FDA approval, its accelerated FDA approval. People, not everyone, it's important to mention again, but some people have begun giving it in certain subgroups. Perhaps the most common subgroup that oncologists have identified for this regimen are patients who have a large burden of disease, who are very symptomatic of their disease, who have lung adenocarcinoma, where we really need to shrink their tumors fairly quickly and by a lot in order to get them to feel better. Because at the end of the day, that is the primary thing that we're trying to achieve immediately at the beginning of our patient's diagnoses. And so it stands to reason then that you would want to select a regimen that seemed to have the highest response rate, highest chance of working in these patients. And again, in that subgroup analysis for the 0% patients and the greater than or equal to 50% patients, as well as in the intention to treat population, the numbers are better for the triplet combination of carboplatin, pemetrexed, and pembrolizumab. So in our very symptomatic, large burden patients, this is a reasonable indication or place to give the triplet combination and something that would be approved. I think at the end of the day, it is a discussion with the patient about what the data look like and about how they're feeling, what their performance status is, what their past medical history is in terms of recommending this and prescribing this. Clearly, patients who have existing autoimmune diseases, this would not be, they would not be eligible for this. Patients who are relatively frail, one would need to consider whether or not giving triplet chemotherapy in these patients, or even doublet chemotherapy in these patients, would be a good idea. So what I'd say is that until really we see that confirmatory Keynote 189 data, it is a case-by-case basis. And I think by and large, this is how practitioners in the academic world and in the community setting have been doing this, which I think is a very reasonable way to end up utilizing it in the accelerated approval phase. One of the concerns that we have had in the academic circles with the accelerated approval of carboplatin, pemetrexed, and pembrolizumab, the absence of mature overall survival data, is the question as to whether or not we are burning through our options too quickly for our patients. And this gets at the question as to whether or not sequencing, for example, chemotherapy followed by single-agent immunotherapy at progression might be better or even similar as giving all three drugs up front. We don't yet know what strategy is going to be the best. But of course, practically speaking, for those of us who opt to give carboplatin, pemetrexed, and pembrolizumab, we are then in a lurch a little bit in terms of what to do in the second line setting, which used to be we gave immunotherapy. So here then the standard of care becomes docetaxel with or without ramucirumab. That really is the gold standard. The trial data support docetaxel ramucirumab as being better than docetaxel. I personally give docetaxel in a weekly regimen for better tolerability in this setting, but it does again consume through 2 lines of therapy at the beginning, forcing us to look for other options in the format of chemotherapy or consideration, of course, of a clinical trial in the second line setting in these patients.